Thank you, Chairman. Ladies and gentlemen, thank you for the invitation as well to participate in this symposium today. When I was a junior and when I was appointed as a consultant surgeon, as many of you were, being sued was not something that respectable people talked about in the past. And furthermore, there was no training in how to deal with complaints and produce relevant and appropriate reports. As chairman of the Medical Legal Committee in our trust for some years, I noted that most of our colleagues had minor or even major complaints over their working lifetimes. A number of my family play sport to a reasonably high level. I don't remember any of them ever going out to play a match in which they said, "I think I will do badly today. I'll kick poorly, I'll pass poorly, I'll fiddle around outside the off stump while the fast bowler's bowling." They all intended to do their best. It is not unreasonable to suggest that professionals like surgeons and others will not also attempt to do their best when they go to work. This was the site on a ward round some years ago. Those of you who read the newspapers, the broadsheets or the red-top newspapers, contrary to what has been said already, will know that there is an absolute fascination with what we do, and our mistakes and errors are often reported in lurid detail. Litigation has been a problem for a very long time, and in 2003, the editor of the Daily Telegraph felt that he should offer his penny's worth on this topic. He had a few points to make. The first is that litigation in this country was following the pattern in the United States, which was escalating rapidly. Secondly, he indicated that the population at large tended to have forgotten that life in general is a balance of safety and risk, and that also refers to our surgical activities. Next, he pointed out that the compensation culture was becoming endemic throughout all the countries of the UK, and the costs were becoming unsustainable. The changes have occurred both in case law and in statute, with case law overtaking statute in the courts, making life very difficult. And lastly, he indicated that the judges of yesteryear took a much more pragmatic view to some of the cases that came before them, and many of the cases that are getting to court today would have been thrown out in the past as having little basis. So for those of you who haven't had the privilege of being sued yet, the pattern in Northern Ireland and very similar in the rest of the UK is more or less as follows. The administration department receives a letter from a solicitor inviting them to send the case notes and relevant records of their client to the solicitor. The solicitor will then instruct an expert witness, and following the instructions of the expert witness will furnish the trust with another letter indicating where negligence has occurred and where the duty of care has been breached. At this point, the clinician will almost certainly be invited to respond and may have to produce supplementary reports as the case develops and as the risk of going to court appears. So what about the reaction to litigation when you receive your first letter? I carried out a straw poll of my colleagues to find out how they felt when they were about to be pursued. And a little bit like the previous speaker, the first worry was a sense of anxiety about how their colleagues would view them if they realised there had been a serious error. Secondly, how management would have viewed the situation, especially if costs were involved or if the clinician happened to be a serial offender. And lastly, how your family would feel if you managed to have publications throughout the media, especially if the matters were severe. And you will know that gynecologists and some surgeons have had trips through the press in the last decade. Second feeling was of anger, of why the patient had bothered to sue me when I had done my best for them, or what I thought was my best? Why were they so ungrateful for my efforts? And then lastly, how am I going to manage this patient in the future? Will I see them again, or will I refer them on to other colleagues for their future care? And then, of course, like a grief reaction, there is acceptance of the situation, and you've got to get on with whatever work is involved in sorting out the problem. And lastly, apathy. Not a very good word, but resignation would probably be better for the older colleagues who have been sued in the past, where they will say, well, this is just like having a wound infection and an anastomotic breakdown, thromboembolic disease in my patients. It has become something of a professional hazard. This advice was given by an Irish surgeon about a century ago to his trainees. In the cynicism of the 21st century, this could also be applied to the skin and its contents. I was a bit interested in what the perceived legal threat actually is to a clinician as an individual. In the early or late 1990s and early 2000s, there was a GMC revalidation pilot going on, and part of that required information on complaints and litigation. And thirdly, I was curious about the risk to a single clinician in terms of an arithmetical risk rather than a threat. I've made some assumptions for this small study which my previous colleagues will probably challenge and my junior colleagues would also challenge, but that this was an average practitioner working in a standard surgical practice in a community where the litigation risk was not any higher than elsewhere, either in our province or in the UK. The information then was for the years 1979 to 2006, which completed my surgical career. The official records of any medical legal complaints were checked from the trusts in which I had worked. I checked the personal copies of letters at home with regard to medical legal complaints. These were only formal complaints where the patient had felt it necessary to seek advice from a solicitor to carry out their complaint, rather than just complaints about the heat of the food and so on in the ordinary running of the wards. And lastly, they were the cases for the surgical team at that time. The concept of a surgical team now seems to be disappearing. Those of you who trained some time ago will remember that in the senior registrar days, lots of work was delegated to trainees, and patients may have been seen and treated by junior colleagues and were never seen by the boss at all. We also have to remember that the surgical team as it exists today is associated with nurse practitioners of the associated professions, pharmacists and others. But when there is a complaint, the end result seems to be a complaint back to the boss of that particular team, regardless of his or her contribution to the patient care. So with regard to the cases that we traced over this 27-year period, there were 35 cases, of which 14 were male. The average age of the patient was 38 years, going from 7 to 79 years. The delay between the incident which caused the complaint and the complaint to be registered with the administration was almost 3 years, but could have been anything from 3 months to 10.25 years. And the delay from the incident until the papers were finally put away at the end of the episode for the 25 patients in which we had the information was 5.5 years, but might have gone on for 16 years. There was no ready classification of these cases, so an arbitrary classification was put together to lump the various complaints into groups. There were some that I thought were really worrying. Some were pretty foolish. There were fractures, and in Northern Ireland until about 10 years ago, general surgeons still looked after trauma and fractures, and there were some very reasonable complaints. So what is the outcome of these 35 cases in which there had been a formal complaint? There is one still around the system, although I have been retired for 6 years. No case got to court. 6 cases were settled out of court. 22, and this is the important piece of information from the clinician's point of view, 22 of these cases were abandoned or withdrawn or just vanished, or nothing more was heard about them. And in 6 of the cases, the clinician was wrongly identified as being the prime clinician in the case. These complaints were distributed fairly evenly across the working time. There were good years in 1979, 1994 and 2006. Most of the cases occurred during the central part of working lifetime, which is what might be expected, when the surgical activity might have been most frenetic. In order to try to put some figures on this, and this data is not particularly accurate, it's from hospital activity analysis, assuming that the years 1998 to 2001 was a typical period of work, the figures were found for those 3 years and an average was taken. So for an average year, there were over 1,000 finished consultant episodes. That is, a patient admitted and discharged without a surgical procedure being carried out. There were more than 600 operations, over 1,200 day cases, more than 3,000 outpatients, a few medical legals and private cases, giving an annual total of patient contacts of somewhere around 6,500 patients. When that works out, by simple arithmetic, it comes to almost 190,000 patient contacts over 27 years. So what about these results? Well, 4 of them were a bit frightening. 15 were really inappropriate from the clinician's point of view. There were 5 fractures going back to the ingratitude within the bone marrow, and 11 of the complaints seemed to be quite reasonable. And as an idea of what they were, missed appendicitis, poorly managed toxic megacolon, a failed diagnosis of TB pyelonephritis over a 10-year period, and bad management of a diabetic foot. Those that were silly complaints, post-operative obstruction following laparotomy, wound problems, the wrong condition was diagnosed by the lawyers, a foreign body in the bladder, which I might come back to, and then painful scars, retained gallstone. With regard to fractures, malalignment complained about, delay in union complained about, surgeon can do nothing about how quickly a bone heals, and a stiff wrist in an elderly person with a comminuted Colles fracture. With regard to those that were reasonable, damaging a nerve at varicose vein surgery, poor wound care, patient having a stroke during a colectomy, and sending someone home with a cannula in their forearm after discharge. It seems inevitable when there's a complaint that this is the paperwork that goes with it. There is an aphorism in the legal world which we should remember, that we sue ourselves with the legal people's help. It would be worth remembering that when you're working your way through an enormous chart to deal with a complaint, you will have to remember that there is a group of expert witnesses out there who are, inverted commas, helping the court. Some are quite prepared to make outrageous claims which make our management of our defence quite difficult. So if, for the younger people, you have to respond to a complaint, here are some simple ideas. First of all, have the original notes. Do not deal in photocopies. Secondly, Do not attempt to amend the notes if you find errors. There will almost certainly be a copy of the patient's chart in the legal department, and later amendments will be very obvious to other observers. Set time aside to work your way through the notes, make good notes as you go along, and then prepare a proper report. I've always thought that writing these reports is a bit like answering a fellowship exam question. You go through the papers and answer what you are asked to answer only. One of my colleagues, when he was teaching his juniors to write reports, used what he called the 3 Ps rule. The first P is the pith of the report. The second P is the padding, the English that is required to make sense of the information being transmitted. And the third P is piffle, and it's important to keep rubbish and nonsense out of the reports and keep them succinct. One of the solicitors for whom I work occasionally sends me a template of how he would like his report written out. And it is important to have a good system to get your report sensible and logical. And the important parts of the report are the commentary, with the citations from the literature and from textbooks, and also to give a strong opinion of how you thought you had managed the patient who had made the complaint. The costs have been mentioned already, but there are other hidden costs, not only the medical time in going through charts, there are the administrative efforts in finding the charts, in photocopying them, setting up meetings, setting up discussions, the legal expenses from the lawyers and for hiring colleagues to support your case, and the emotional upset of having cases hanging over you for up to 10 years, wondering what on earth is going to happen. And lastly, there are some people who do not like close proximity with barristers and judges. So what conclusions can this very primitive audit tell us for the clinician? First of all, the risk of being sued is not numerically great. Secondly, keep away from things that you don't know very much about and in which you are not adequately trained. Should the cases be filtered, 22 out of 29 just vanished. Should there be a committee that looks at how cases get to court? An external committee of lawyers and doctors may have been tried before. It should possibly be tried again to try to take the inefficiency out of our system. Should we take our retribution on the patient who has sued us? Unlikely. Should we attempt retribution on the colleague who gave the expert advice that allowed the case to proceed? Possibly. Should we attack the lawyers who brought the case? Possibly. These are not foolish ideas, because the teaching profession has now got fed up with being assaulted and abused, and they are looking at the possibility of taking legal action against those who attack them. It's possible to reduce the risk by just reducing the amount of work you do. That's straightforward. Unfortunately, that will get you across the administrators who are trying to keep their statistics satisfactory. And lastly, it's pretty important to try to keep your name out of the press and out of the media. So in summary, Mr. Chairman, getting close to 200,000 patient contacts led to 29 actual complaints, of which 6 were settled. Of these, 5 were trivial, 1 was large. Of the 5 small cases, they could possibly have been won had it been suitable to do so, but the lawyers and the trust took the view that it was easier to settle without any acceptance of responsibility or blame. So finally, if the heat in the operating theatre gets too great, there is one other option. You might join me in retirement. At the end of the day, the threat is great, the risk is very low. Thank you very much for your attention.